Thank you, Prajakta. Our next speaker is going to be Dr. RONAK SOLANKI, who will be speaking on my first subluxated case.
Hi, good morning, everyone. So I'll be presenting how would you go about doing your first subluxated cataract. So we'll start off with, I won't bore you with the anatomy, physiology, and definitions and the devices which are used, because by the time you're planning this, you must be quite familiar with it. Anatomy, as I said, you need to know it because the planning of the surgery and the small steps which may be helpful over there. We'll come to the clinical evaluation. So right before the surgery, you have to plan it well, because this is the first case, so you don't want to take a too complicated case. Especially you don't take the cases which are hereditary, like the Marfan syndromes, where there is a subluxation is grossly decentered. Evaluate the lens position, the visualization of the extent of the zonular defects in terms of clock hours, the AC depth irregularities, the iridophecodonensis, the vitreous present in the AC or no, because that is a very important factor. Pupil changes and the grade of cataract, but the grade of cataract is going to give you the confidence of going ahead with the surgery or no. And a proper evaluation of the posterior segment, because in traumatic cases, you may do one part and you may miss out on something else. So these are just practical steps where the approach to your first case is identify the amount, the amount of subluxation is important. The goal is to save the bag and fix it. Bag removal, if it's to be done, and then you have to plan a secondary IOL. There are various types of IOLs and devices which have their own indications. The grade of cataract, as I said, is important because you don't want to have more complications in terms of zonular dialysis, extending the posterior capsular rents, nucleus drops, and various other things. Vitrectomy also is needed. So the surgical goals are two. There are short-term during the surgery where you have to do a capsular stabilization, and a long-term where the IOL and bag complex has to be fixed. So since it's the first surgery, we'll do a very practical approach where these are the things which I wanted to take care of during the surgery, because every step is very important, right from planning the incision site, the type of incision, because if you suppose you're used to doing a temporal phaco and you always do a temporal, but if intraoperatively or you want to plan a secondary IOL or a CTS fixation, it may just hinder your wound area. The site of the wound is very important. In case you need to convert it, a vitrectomy is done, SFIL or claw fixation. Plugging the area of zonular dialysis, it helps to tamponade and push back the vitreous and prevents the trypan blue from going down. It seems a very silly small step, but it's very important in such cases. A continuous curvilinear capsular X is important. You have to start in the opposite site of the zonular dialysis. Sizing is adequately required. Support with hooks if needed. Use forceps and center on the IOL and not on the Purkinje image, because in gross decentration, you may just falsely, whatever is seen, you may do it and then it becomes an eccentric capsular axis. Hydro procedures, you just need to be very gentle about it. Nucleus rotation, there has to be minimal nucleus rotation. I use a technique where I use capsular hooks to distribute the forces and then rotate the nucleus after doing hydro. Coming to the phaco, there are lower parameters to be used. Use direct chop techniques. Always be liberal in your use of viscoelastics, especially cohesive viscoelastics. Lift up the fragments to prevent stress on the zonules. And keep observing the PC, because your heart is going to beat faster the moment you see your PC fluttering over there. Last piece is very important, because you always have to anticipate that something can go wrong, because just because you can't be relaxed at the last piece. A cortical cleanup is very important, where tangential peeling and peripheral to central pulling is required. Timing of the CTR is a debatable thing. It depends on your surgeon preference and also how well the cortex has been released with your hydro procedures and maneuvering in the bag. Later then, capsular fixation will be required. The lens can be a single piece lens also you can put if you stabilize the bag well. And a 3-piece sulcus fixation and an optic capture can be done. And the worst is you have to plan for the worst that could happen. Keep a standby VR surgery ready. A nucleus dislocation can happen, vitrectomy or via the pars plana approach, and secondary IOLs. So keeping all these points in mind, we went ahead with the first surgery. This was my first surgery a few years back. So I'll just play the video. Okay. It's not playing. Okay. So if you can see the subtly there's a zonular dialysis of around 3 clock hours. I put intracameral adrenaline, which reveals a little more than what I had expected, because on slit lamp it wasn't dilating. Tryptophan blue is an important step, as I said. What happens is I've put a tryptophan blue. In this case, I'm not shown it, but now what I do is wherever the area of zonular dialysis is there, I put a cohesive viscoelastic so that the tryptophan blue doesn't go behind. And see, this is what happened. This was the most recent case I've done. I put a tryptophan blue. I was waiting for a tricot injection, and it has trickled back, and I could not see anything when the retro illumination is not there. So it's a very important step to not let your tryptophan blue go behind. Your visualization aids in your surgery. A clear phaco incision of 2.8 was done. You could see that the zonular dialysis is almost around 5 clock hours. So I've started the CCC in the opposite direction. Using forceps gives a more stable approach. Some people also use hooks during the extension of the rhexis so that it stabilizes the bag more. This was a traumatic young patient, so it was fairly stable. A gentrohydral procedure was done. You don't let the whole wave come to the opposite side or pop it out. Just enough to release the corticocapsular adhesions. Since this was a large 4 to 5 clock hours zonular dialysis, so after this, just small bolus of injection. I've decided to fix the bag first with 4 capsular hooks. And then I've decided to rotate it because it has distributed the forces well. The anterior zonules were pretty fine. Going ahead with the phaco surgery, low parameters, a direct chop technique. Important is to lift it slightly in the capsular plane or the iris plane and remove the pieces because it will prevent the bag stress. You lift it with your second instrument and get it in the central safe zone and emulsify it. If you can see in the quadrant, you may see some fluttering of the PC, and you have to be very careful about it. Otherwise, the whole bag may just come out. Replenish with OVDs so that the PC is pushed back. Even with lower, now this is the last piece. I just thought I was relaxed and done, and just see what happens now. Okay, the PC just caught. I'll just slow it in show motion again. Use timely reflux and left it back. Take your time, put your cohesive viscoelastics. There's no PC rent, it just had caught and I have left it at time. Cortical cleanup was done. So in this case I preferred to put a CTR after doing this because the bag was fairly stabilized. I preferred to do it with the injector because you can place the eyelets opposite side just by going from the same wound. Otherwise you need to put it through another side port. See, it will come in the opposite and it will stabilize the bag now. Next is a 3-piece IL was inserted. The trailing haptic is important in these cases where there is a lot of zonal stress to not dial it, but you can just place it. I use a bimanual technique where I just depress the optic and just place it under the margin instead of dialing and rotating it because that will cause more of disruption of the zonules. Removing the capsule. The bag looks very stabilized. I didn't want to put a CTS segment because it was a young patient, traumatic, and I felt the lens was pretty stable. So I did not want to do it too much of intervention. And that's it. That was the end of the case. Yeah, that's it.
Very comprehensively explained, Ronak. It was really good. All the points were very well covered, and I think all the points were, each of them was very important.